Well, hello everyone. So excited to have you for the inaugural What the F. I'm going to say it with a little snazz. Um, it's our Fibroid Research Forum and discussion. We really want an opportunity to share with you um, what we're finding as the research committee. So we're going to introduce ourselves a little bit more in detail. So it's me, Tanya Leek, and Dr. Rochelle Wolf, and we have a very esteemed guest with us today who we'll also introduce in a moment. So I wanted to do just as a quick start, just so we can ground and make sure that when we're talking, that we're addressing any reasons that you came to this. What about this topic, about this session, about this organization, whatever brought you to this conversation tonight? If you can just throw it in the chat. You can maybe just say your name and throw it in the chat so we kind of get a sense for what are the hot buttons for tonight, so we can really make sure that you get something out of, get what you want out of this evening. And thank you all for joining. Spending your Wednesday holiday party, probably, delay that you've done. So anybody, everybody's shy. Anna, thank you. Okay, Yolanda. So Anna, just general information, because you've got fibroids and endometrial polyps. Yolanda, any specific reason you joined, or again, general information? Oh, I love that. Dr. Cheryl, thank you. You're a consultant for women living with uterine fibroids. Alberta, Canada. I love it. We're international. So Annie, nice to meet you. Okay, chasing down no answers. I think we might use that quote if that's okay, because that's that's kind of the sort of refrain from everyone. So yeah, so unfortunately the doctors you see have not been helpful, and that's also a common refrain. Tara, hi. Tara, we met in person in Charlotte. I like to keep up with information. You have fibroids and headed to menopause. Um, okay, prevention is a question without an IUD. That was very uh, that's something that sounds like you heard from your provider. Okay, so and Eufy, we've got a Dr. Rochelle Wolf can answer any questions on Eufy because she is an interventional radiologist and actually does that procedure. She had a not effective one, so we can talk a little bit about when it's sort of appropriate and what your definition of effective is, because again, that's part of is what your preference is that we often talk about. April, Charlotte, so we probably met. Just wondering if anyone else has been told bleeding is not normal. Okay, so we're going to talk about normal. Okay, your iron levels were too low for your myomectomy, Sarah. Thank you for sharing that. Okay, been prescribed for Lisa to stop her periods. Recent heavy bleeding and clotting. Okay, have a consult next week. All right. Thank you for sharing. That's going to be very helpful for us and certainly the clinicians that we have here to be able to give you at least the information that will help you work with your provider for hopefully the best outcomes. All right, with that, I'm going to throw up a little presentation and and we'll talk about the agenda a little bit. Okay, let's see. All right. So again, welcome to our first December 2022. We're going to be we're kicking off early. Research monthly fibroid town hall and forum. So really a lot of this is going to be about conversation. So our topic for today is, am I bleeding too much? And we'll talk a little bit about why that's our topic today. So we're going to talk to you about who your hosts are and who your hosts will likely be. We may do a little tag teaming on these monthly town halls. And we have a very special guest, as I mentioned, so we'll introduce her. And then we'll just give you an introduction to the topic, and hopefully that will give you some good basic information. And then we'll start to dive into specific questions you have, or maybe if either Dr. Wolf or Dr. Stewart have specific comments based on some of the things that you all have brought up as part of kind of setting expectations and hopefully goals for today. All right, so we are the directors of research for the White Dress Project. I am a certified health and wellness coach. I have a special sort of coaching program around women with fibroids. I have had fibroids myself, and so the program actually came out of some work that I was doing personally, which was more around, I'm a holistic practitioner, so more around sort of the mind and body. So focus on stress management, sleep, recovery, and really just kind of getting to a place both mentally and physically where you are less likely to recur. So with that, Rochelle, would you like to introduce yourself?
So I'm an interventional radiologist. I've been practicing for about 17 years. In my career, I've had a very specific interest in women's health. So I kind of, in my practice, focus on uterine fibroid embolization as one treatment option for uterine fibroids. I really do believe in a very strong collaborative team in treatment of fibroids. So working directly with gynecologists, patients' wishes and desires to try to come up with the best outcome, because we do have multiple ways to approach fibroids. And so there's really how to personalize the treatment options for patients.
Thank you, thank you, thank you. All right, and we have Dr. Elizabeth Ebby Stewart. And I did not know your middle name, and now I do. And that is lovely. And Anella, is it? I want to make sure.
Yeah. Okay. Being a Southerner, they took Ann and Nell and put it together.
I love it. She is an internationally recognized expert. So you guys don't realize how lucky we are this evening in the field of uterine fibroids. But she also focuses on adenomyosis and infertility. She was the founding clinical director of the first comprehensive fibroid center at Harvard Medical School and Brigham and Women's Hospital, which, again, you are really lucky she's here. So she's authored a number of peer-reviewed articles, worked on clinical trials, and she has a book called Uterine Fibroids, The Complete Guide. So she is a clinician first. So she has contributed to the clinical understanding of lots of different facets of fibroids, which of course I love because there are so many facets, including not only the epidemiology, but also economics of fibroids and fibroid treatment, the genetics, the disparities, and developing alternatives to hysterectomy, which again, a lot of folks that we talk to are looking for and interested in. So she's also worked with industry on development of drugs and devices for fibroid treatment. So again, looking at other ways that we can attack this sort of, we call it, an epidemic. In terms of, I'm just gonna, we'll leave it at that. Her education is extensive. So again, you're super fortunate. We are super fortunate to have her here. This is our special service announcement. This is the only commercial you will have today. We have our 2022 White Dress Project Fibroid Survey. So it is our first survey as the White Dress Project. It was developed and reviewed by a cross-sectional group. So we had women who had experienced fibroids, physicians, researchers, and our objective was really, and we're going to share some of the things that we found in our preliminary results. We want to create a more detailed picture of how people with fibroids are experiencing them, discover opportunities to improve and innovate, and work with folks like Dr. Stewart to understand perhaps where research should go so that we can really improve the experience that women have with fibroids. All right, so how did we get to this topic? Am I bleeding too much? First of all, we discovered from the survey that there was a lot of normalization, and even in our conversations with Dr. Stewart, which we have fortunately as an informal advisor, we hope to formalize that relationship soon. And we really wanted to focus on providing education and awareness because of the risks of heavy bleeding. And we saw people, responding to the survey that said that they had heavy bleeding and weren't planning to follow up on it. And again, heavy bleeding, right? What does that mean? What is it? What's bleeding too much? What's abnormal? And why is it important? What is a typical period? And again, everyone's biology body is different, right? So what is typical? And really that's what you need to know, is what's kind of outside of your, what's the normal range, and then where do you usually fall? But we'll talk about that. And what are the risks of bleeding too much? We're going to talk about two things that you may or may not have heard of: anemia and menorrhagia, and hopefully leave with practical steps to take to ensure your best health and well-being. All right. So with that, I'm going to let Dr. Wolf talk about a couple of things. And Dr. Stewart, if you have anything else you wanted to achieve today, any thoughts? No. Okay.
Oh, whatever participants want to know about, I'm happy to talk.
Thank you. Thank you. Dr. Wolf, why don't you take it away with this?
Yeah, so just a couple little bit of like definitions, just, what is menorrhagia, or the technical term for basically heavy menstrual bleeding. And according to the Center of Disease Control, menorrhagia is menstrual bleeding that lasts more than 7 days. And it can also be just very heavy menstrual bleeding. And so again, what is heavy menstrual bleeding, right? If we go on strict, definitions of what a normal period is, which is typically lasts 4 to 5 days, and the blood loss is small, about 2 to 3 tablespoons. I don't know what 2 to 3 tablespoons of blood loss means. So trying to put it in a little bit more practical terms for everyone is, basically if you need to change your tampon or pad after, less than 2 hours, that's a sign of heavy menstrual bleeding. If you're passing clots, typically the size of a quarter or larger, that's an indication of heavy menstrual bleeding or menorrhagia. Right now, about 1 in every 5 women have menorrhagia, which equates to about more than 10 million American women each year. Tanya, can I? Oh yeah, so here also from the CDC, it's just sometimes a picture can kind of say 1,000 words. Nowadays with some of the pads and absorbencies, it can be a little bit more difficult to understand. But basically, looking at a pad or a tampon, what is considered light, moderate, or heavy bleeding. They've actually come up with like a chart to track the bleeding. So you kind of look at, how many pads or tampons are used each day, and kind of record how saturated they are during your period. And if they last longer than 10 days, you have to use another chart. And it's not, and then you can score it and add it. And if it's greater than 100 points, it can indicate heavy bleeding. But I think sometimes it's not so much the specifics of the detail, it's just to really kind of understand by looking at your tampon, looking at your pad, kind of figuring out how frequent you're having to change them. I typically tell patients, if you're changing what, an 8 tampons or pads a day, that's a sign of heavy bleeding. If you're getting up in the middle of the night, changing a pad or tampon or soaking through, if you're having quick gushes of blood, or again, passing clots larger than the size of a quarter, these can be all signs and really should kind of provoke you to start a conversation with your healthcare provider.
Yeah, and I just want to underscore that. I mean, because it is so difficult, as Rochelle was saying, that the pads are different sizes, and you have the super absorbent, and it's hard to we want to have the image that helps guide you, but it really is important to have a discussion with your healthcare professional. And I would draw your attention to the instructions. And I think it's interesting. They say if it's longer than 10 days, please continue to score using a second chart. I would say if it's longer than 10 days, That's already go straight to the doctor. And then the other thing that they mentioned there is if you have any flooding or gushing that is enough to affect your daily activities and quality of life, put a check for that day. And I would say again, maybe that's also a call to your healthcare provider. And especially with virtual visits and things like that. I mean, just start the conversation. Maybe that gives you a little more sort of flexibility in terms of contacting your healthcare provider. But I really think this is about awareness of the fact that clots are an indicator. I mean, we're really all about understanding what's going on with your body, one, and then two, making sure that then you can act on it in order to make sure that you don't have untreated conditions that can eventually become much more difficult to treat and also just cause you much more trouble. And I think I just put this in just so people could see it a little more in depth. And I think Rochelle talked about, they said like a grape and like a strawberry. And I've had grapes that are bigger than strawberries and strawberries that are bigger than grapes. So, again, have the conversation. Oh, sorry. This is the one that got a little bled off. Excuse the pun. Do you want to?
I'm sorry, I'm coming off a mute. So, so from the Mayo Clinic, where Dr. Stewart is from, they kind of have a definition, more approachable definition, I think, to what is anemia. And basically, anemia is a condition where the blood doesn't have enough healthy red blood cells to provide oxygen to carry around in the circulatory system. So if you're not having enough healthy red blood cells to help, you can get a lot of symptoms from this, which may include fatigue, pale skin, shortness of breath, lightheadedness, dizziness, or a fast heartbeat. The technical term is called palpitations. So what is not enough? Basically, if you're a healthcare provider, draws a blood test to look at your hemoglobin. A hemoglobin in general less than 12 is a sign of anemia. About 17% of premenopausal women and 10% of children in the population are now considered iron deficient under the current thresholds. And so there are several different types of anemia. I'm an interventional radiologist, not a hematologist. But in general, heavy menstrual periods do lead to something called iron deficiency anemia, causing, again, symptoms. Another symptom is kind of weird cravings, something called pica, typically craving ice. I practiced out in Atlanta for a while. And, one of the first questions we would ask is, do you have a favorite type of ice and which gas station? Racetrack and Speedway, I think, were the two different ones. If anyone's from Atlanta, women could actually tell which gas station had better ice based on their preference. So like I said, it's just kind of understanding some of the symptoms. Some of these other symptoms can overlap with other things, but just be aware that if you're not feeling well, if you're experiencing any of this, again, it's awareness to start that discussion with your healthcare provider.
I would just add in here too, just like people who live at high altitudes may have adaptation of their bodies. I've seen a lot of women with fibroids who've just gotten so used to being so anemic, they don't really even complain of anything until the doctor says, I'm very worried about this number. That I had a woman walk into my office just a couple of weeks ago whose hemoglobin was 6, so about half of what it should normally be. And I think some women just keep powering through and don't realize what's happening.
And Dr. Stewart, can you just talk about, I think, let me just see. I'll say this first, and then I do want to ask you kind of, because there is a risk to anemia, and there is a risk to this kind of normalizing it and saying, hey, I'm just always tired, and especially around my period. And there was a statement from one of the research articles that we were looking at that says anemia is often overlooked by doctors as the cause of health issues, especially and particularly because we're talking about it, fibroids. It could be linked to any number of other health issues, but the bottom line is that it can get very serious. So we had some concerns about this. And again, this relates to why we wanted to review this topic, is because our survey results suggest that 67%, so 2/3 of our respondents that were unfamiliar with fibroids. So they said they either kind of knew or didn't know what fibroids were, identify as having heavy bleeding. Now, again, we didn't ask for the details on that, but 1/3 of those respondents have no plan to follow up. And if this is an issue of anemia, whether it's fibroids or not, this is a serious issue. And that's part of why we just want to develop more awareness around kind of what is in that range of sort of what's expected, maybe not even normal, but what is expected. And then, does that require a conversation? And 51% of those who have been diagnosed with fibroids at some point have also been diagnosed with anemia. So they do often come together. And so, our conclusion was that normalizing abnormal bleeding leads to, really late stage treatment of things like fibroids and other conditions, and that can have really significant ramifications. So I don't know if Dr. Stewart, you want to add to that in terms of the types of things that,
Well, it sounds like our participants have had some pretty terrible experiences seeing what's coming through on the chat. That I think of anemia as putting you at risk for two major things. The first thing is, especially if you've got fibroid related bleeding, that sometimes you don't get to choose what your fibroid treatment is because you end up in an emergency room and you're not able to speak for yourself. And I've seen some women who've ended up with a hysterectomy because of being anemic and not being able to choose things. But certainly anemia affects your heart, your lungs, your kidneys. It can have significant medical consequences. So I think it limits your ability to choose a fibroid treatment that's right for you, and it can have long-term medical consequences. The only good thing is that women with fibroids tend to be otherwise young and healthy, so they can withstand a lot more. You had the same blood count and you were a 60-year-old person who had coronary artery disease, you would be in a lot of trouble.
Yes, thank you. I just got into the chat, so thank you for alerting me to that, Dr. Stewart. I hadn't seen, but yeah, so it sounds like, and it's interesting because I've heard these stories of hemoglobin in the single digits very often. And I guess I'd ask, both Dr. Stewart and Dr. Wolf, if you have any thoughts, and I know, not a hematologist, I got it. And Dr. Stewart, especially because you've seen a lot of the research. And this was a WHO kind of declaration. I did see that there were differing kind of ranges of what is deemed anemic. Do you think that there's some opportunity to potentially look a little earlier at when, those hemoglobin numbers are starting to go down? And what would you suggest for women who, are take a look at your, your CBC, your actual blood count report and understand what should they be looking for, I guess is the question.
I think there's two issues that I see. The first is that there's a perception among medical providers that reproductive age women tend to be anemic because they're losing blood through menstruation. Mm-hmm. So again, sometimes they don't work it up as aggressively. So I think that's an issue. The other thing is many primary care doctors don't personalize their evaluation for anemia. So instead of seeing a 28-year-old African-American woman and saying, oh, gee, the most likely reason she probably has anemia is menstrual bleeding and fibroids, they think, oh, colon cancer or, something else that could be causing it, but probably isn't the prime time likely answer. So I think that particularly if you have a family history of fibroids, if you're African American, if you have long or heavy periods, you're probably at least mildly anemic. And I think that many women might benefit by taking a multivitamin with iron But I think the iron also is constipating. So for many women, that's the treatment is worse than the benefit that they perceive.
Thank you so much. If there are any questions, go ahead and post them in there, and we'll kind of filter them, because we don't want you to lose them if you're thinking about them, because we want to make sure we have a robust conversation. Okay, so I think from that, I mean, that's really the end of the sort of topic introduction, and from here we just want to start a conversation around you've heard some of these things, what comes up for you based on your experiences, etc. Questions?
If there's no questions, I can probably just start, a general question and, even ask Dr. Stewart, in your practice, when women come in with, family history of fibroids and saying, I'm tired, I'm getting short of breath, kind of what would be the typical kind of workup that you would offer to patients? So, if a woman listening to this topic kind of says, oh, I can relate to that, just knowing that she gets good quality care, regardless if she's in a small rural community or a big metropolitan area, kind of what are some things that she should be asking her provider, or what should she expect her provider to do at a baseline?
Yeah, so I think if you're coming in and you're saying you're tired and have heavy periods, I think looking at a complete blood count to make sure that you're not anemic, and that also all the other blood cells that you want to have in a normal range are good, because there can be some rare things happening there. The other thing I typically also check is thyroid function with a blood test called the TSH. It's not specifically related to fibroids, but it's a common disease in women. And if it's out of whack, you can also have heavy menstrual bleeding and you can feel fatigued. So that's usually where I start with blood work. But I think also getting an ultrasound to see where the fibroids are and how big they are and how big the uterus is. That even if you've just had a pelvic exam, sometimes your uterus can feel normal, but there's a big fibroid sitting in the middle that's giving you heavy menstrual bleeding, or it's much easier to feel a fibroid on the front of the uterus than it is to feel a fibroid on the back of the uterus. So kind of trying to get a diagnosis and then put together a plan makes sense to me.
All right, I was trying to summarize that. So the CBC, the TSH, and the ultrasound. And I was going to add, and I think I talked to Dr. Stewart about it, and Dr. Wolf has been my sort of advisor on my sister actually was bleeding for about 30 days. And I relate to, I think, I don't remember the name, but of someone who she was, close to menopause and had been in a wait and watch for her fibroids. And it was interesting because when I shared with her that the CDC sort of, tracker that we just shared, she said, yeah, that would have been helpful because she had very small clots. And of course, when she bled for the 30 days and eventually wound up in the hospital with the, I don't know what it was, 6'3", whatever it was, that she was passing blood clots the size of her palm. And so, yeah, and unfortunately, I think, one of the things that we talk about, we want people to be aware, and to Dr. Stewart, what you were saying is that she was kind of in that, she decided to wait and see because she thought menopause is coming and, it's good, they're going to shrink and it's going to be fine. But that did not, kind of happen. And she continued to bleed. And what happened was the fibroid also grew significantly large. And we're now, I know this is very rare, but we're now kind of, there's going to be a whole pathology, to determine whether or not it remains a benign tumor or not. So again, I guess my fresh out of the ICU, which is where she wound up, I am very, very So that I want to be insistent that, you really become aware of what is normal for your body, and know that if anything is impeding your daily function, certainly, but also if you see some of these things that we're kind of making you aware of now happening, then please have the conversation. And if you're not getting, if your doctor says, oh, that should be fine, then please, 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 if you can, because I know this is not just get a second opinion. It's not as simple as it sounds for some cases, depending on your insurance, depending on lack of insurance, depending on cost. I know Dr. Stewart has done stuff around the economics, but it is something that should not be overlooked, because it can cost you a lot more in terms of time, pain, effort later.
Yeah. And there's a couple of key things about women and fibroids as they get close to menopause. And I was taught that, well, if you can get women close to menopause, you can just kind of do watchful waiting. But the research actually shows that fibroid growth slows for white women, but not for Black women as they approach menopause. So for Black women, it's a bigger issue. The second thing is that as you get closer to menopause and in that age 50 time point, other things increase in risk. There's more risk of cancerous or precancerous changes of the lining of the uterus. And there have been some people that have been doing research to show that, if you've had bleeding throughout your reproductive life with fibroids, then as you get close to perimenopause and menopause, you're not freaked out by just a little bit of bleeding, but that can be a sign of postmenopausal bleeding and cancerous or precancerous conditions. So kind of the same story in a 52-year-old woman could prompt very different concerns than the same story in somebody who's 25.
Well, thank you. I wish she had gone to see you. Okay, so we're going to move on to the question, what is your perspective on the Orilissa tabs as a treatment for fibroids versus other medical procedures?
Okay, so Orilissa is actually a drug that's approved for endometriosis and not for fibroids. It has a hormone blocker called elagolix. But there's a new class of medications that are very effective at controlling fibroid-related bleeding that have the same, one of them has the same ingredient as Orilissa, but it's combined with very low doses of estrogen and progesterone. It's called Orion, and that's the one that's approved for fibroids. And there's a second medication called relagolix, that's combined with small amounts of estrogen and progesterone that is also approved. So both these drugs are approved to be taken for up to 2 years and are very good at controlling heavy menstrual bleeding. And it's also clear that they seem to relieve symptoms like pain and pressure as well. So I think that for many women, getting control of their symptoms with medical therapy is a good initial step. For some women, it may be all that they need. And in other women, it will at least settle things down, build up their blood count, give them time to explore other options. I'm trying to do less surgery and trying to do surgery only when we're close to needing to optimize the uterus for a woman who wants to get pregnant.
Okay. Okay, I had Orion, and then what was the other? I'm sorry, I just wanted to put it in the chat.
It's called, well, Orion contains elagolix, and the drug brand name is called Myfembry, which contains relagolix.
Okay.
And there's a third drug that's available in Europe, but it's not available here yet.
All right. And we have a question about the same question for hormonal IUDs. What's your perspective on hormonal IUDs as a treatment for fibroids? Because some people did mention they got that recommended and it did not work.
Yeah. So first of all, unlike the Myfembry and the Orion, The IUD really only helps with bleeding symptoms. It doesn't do anything for the size or what we call bulk-related symptoms. It also may have a higher risk of being expelled in some women with uterine fibroids, and we don't have good markers for who's going to expel it and who's not. But it does seem, at least clinically, that the women that have the fibroids on the inside of the uterus may be the ones to be more likely to expel the IUD, or the women that have really heavy bleeding. And that's a pretty frustrating thing if you've spent a big copay to get an IUD placed, and then it is washed out with your next period. So I think for women as they're approaching menopause that have modestly heavy bleeding, it's a great tool, or young women who have heavy bleeding and also need contraception can be a good tool.
Great. So are there specialists that folks should ask for, that they should ask their PCP for, or for fibroid menopause management?
That's really tough, because every gynecologist will tell you they're a fibroid expert, but not every gynecologist really is a fibroid expert. I think in general, you want to be going to a place where they have a whole team that works on fibroids. So you have the input of the interventional radiologist, you have the input of the gynecologist, in general, if you can get to a medical center or a freestanding fibroid center, that's probably going to give you more options than if you're just seeing someone who does the whole range of OBGYN practice, from delivering babies to doing pap smears. Rochelle, you have any suggestions for how to find a provider?
Yeah, I think, asking around. So, I come from a different approach where I'm in a freestanding interventional radiology center. So people are like, well, how does that relate to fibroids? So we try to raise awareness. And then I have, my set of gynecologists kind of throughout the Twin Cities metro area, depending on kind of geographically where you live. Because again, and this isn't, I always say in medicine, we all have to kind of specialize. So, like I know a little bit about a lot of things, but I know a lot about a few certain disease processes. And so that also comes with your gynecologist. So there are some gynecologists who are really good at treatment of fibroids, infertility, menopause, and then having both the medical background and the minimally invasive skills to also treat fibroids. So I, really work closely and collaborate with a few gynecologists that I know, okay, I see a fibroid, and you know what, well, you may also be a candidate for, even a combined, radio frequency ablation with the Acessa Sonata and potentially like a myomectomy. Or I can do a fibroid embolization, but you've got a big submucosal fibroid and know that you're going to be at risk for sloughing that. So we work together to do part of the treatment, and then they go to the, my gynecologist, who then does the hysteroscopic myomectomy. So when I talk about, if you go to a provider and they say there's only one treatment option for your fibroids, that's probably not the correct answer, because as you'll learn through the white dress and the more you research, there's medical management, minimally invasive, IR procedures, and there's more and more things coming out. So if there was just one perfect treatment, we'd only have one. So it really comes down to size, number of location, and, just your own expectations. And like Dr. Stewart was saying, just having that really, really good comprehensive team that really collaborates and listens to you.
Thank you so much for that. And I do want to go back to, and I see a lot of questions about, fertility, and is it possible to have a vaginal birth? And I'm going to put a little pin in those, just because we're going to probably do something around fertility and pregnancy. And I do want to kind of, I was going to say drain the heavy bleeding questions, but I feel so I'm on this roll with my puns. And so there is a question from April. Is it normal to be prescribed 10 milligrams of norethindrone to stop control heavy bleeding and her constant bleeding? She went from heavy bleeding and clots to no period to a 3-month period.
So norethindrone is a drug that's sometimes used to control fibroid bleeding. That a lot of estrogen and progestin containing drugs are used. It's less used to be at that high a dose. That usually there's lower doses, but there may be specific reasons why the provider chose that. Sounds like it worked.
And I wanted to, I'm going to refer back to my sister's case, which she did give me permission to share, by the way. I'm not just kind of mouthing off about my sister, but, you know, one of the things that happened, again, going to this whole concept of sort of putting off having this discussion and really kind of addressing fibroids with this watchful waiting approach, her fibroid grew extremely large. And it was pressing on some of her major blood vessels. And they do believe that it caused a blood clot that did travel to her lungs. And I saw someone was talking about a pulmonary embolism that they had. And what wound up happening is it became a very complicated case because they wanted to give her blood thinners for, of course, the embolism. But she, of course, was also still bleeding vaginally. So she was still having the bleeding. And of course, you know, if you have blood thinners, that now increases the bleeding, of course, to loosen up the clot. So it was kind of one of those things that it was, her treatments were fighting with one another. And so again, it just made her case much more complex and much more risky, in all honesty. So I do, you know, encourage you to really look at where you are. If she had, when she was having the strawberry size, quarter size, whatever we're going to call it, blood clots, and kind of pushed maybe the issue a little bit more with her provider, we might not have gotten into that sort of complex situation. Sarah did ask, though, specifically for Orion, is that safe to use if you have a pulmonary embolism? Sarah was diagnosed with that in September.
Yeah, and that's a tough one because every drug that contains any estrogen or any progestin in it carries a big black box warning that says this medication is associated with blood clots like pulmonary embolisms. But with drugs like Orion and Myfembry, you're actually having very low doses of estrogen and progestin. And so for a premenopausal woman who's used to ovulating every month and her hormones are going up and down, being on that medication actually lowers her hormones probably decreases the risk. And there weren't blood clots seen in the clinical trials. So the legal answer is no, you should not take the medications if you've had a pulmonary embolism or a deep venous thrombosis. But the medical answer is more subtle, and you need to take into account a lot of other factors, just like Tanya's sister. If you have a boulder-sized fibroid sitting on your blood vessels and increasing clots because of that, it may be a different situation than if you have a relatively small uterus.
All right. There is a question about, well, I did want to share, Yolanda shared that she wanted to preserve her organs even at 43. She's 52 now and the fibroids are back. So I assume maybe in the past you had a myomectomy. I have an IUD, Kylena. This intervention greatly improved her quality of life, and she is no longer anemic and much less anxious. And I'll chime in there with what we've seen in terms of the survey with the mental health implications of all of this, right? I mean, I am worried about my sister's mental welfare at this point because she's just gone through a lot with all of the complications. And so, you know, really give yourself a lot of grace as you're going through this, especially if you're maybe not as satisfied with your provider and you're looking for other providers. We hope the White Dress Project can be a resource. Please send us an email at wecanwearwhite@gmail.com, or you can send it to Rochelle and me at our names at Tanya or Rochelle at thewhitedressproject.org. But it is something that is, again, it's a cycle, right? So the more stress that is caused by whatever bleeding that is, especially if it's affecting, again, your quality of life, that's going to actually exacerbate issues that you're having around bleeding and fibroid size and all of those things, right? So it is really, really important that you give yourself some grace with this process. And I know it can be challenging, but there is a way forward. That's what I say.
And again, it sounds like that was a perfect use of an IUD. Fibroids before had a major intervention. Things got better for a while. And now as you get closer to menopause, some heavy bleeding is an ideal case for an IUD.
Thank you, Yolanda. Thank you for bringing it up. And Yolanda did. I'm sorry, I missed it up ahead. She did have a robotic myomectomy. So is Sonata and Accessa options for small fibroids? And I know we've got.
Yeah, well, I think the real definition is small. Both, for people who don't know, they're both techniques that use a kind of a radio frequency ablation wand that that you stick into the fibroid and use energy to destroy the fibroid. One is used at laparoscopic surgery through the outside of the uterus, and the other one is used through the inside of the uterus through hysteroscopic surgery. And so, yes, they're probably best for fibroids that are in the range of about 2 to 5 to maybe 6 centimeters. So they're not good at the fibroids that are the size of a pea, and they're certainly not as good for fibroids that are the size of a grapefruit.
Yes. Rochelle, I don't know, we heard from the person who said Eufy. Do you want to talk a little bit about Eufy and kind of what it's appropriate for?
So talking about heavy menstrual bleeding and uterine fibroid embolization, basically it's a technique that's been around for over 20 years. It was first started to use kind of in postpartum hemorrhage and pre-op patients who were undergoing hysterectomy and they wanted to decrease the blood loss. So the uterine fibroid or uterine artery embolization was performed. And over the years, we found, that when women have heavy menstrual bleeding related to uterine fibroids, we've got an over 90% efficacy rate of really controlling that heavy menstrual bleeding. So I say, nothing in medicine is perfect, but about 9 out of 10 likelihood of controlling your heavy bleeding and getting you back to a normal period is actually really good. When we look at kind of, those fibroids get big and bulky, so bulk-related symptoms, kind of pushing on either the bladder, the colon, pelvic pressure, painful intercourse, we're still really good at probably anywhere from 85 to low 90% in treating bulk-related symptoms. When I first started out, we used to, say early in my career, if like fibroids were greater than 10 centimeters, maybe not as great of an option. And what we found over time is, women have undergone fibroid embolization, and even with big, bulky uterus and fibroids, we still can control symptoms pretty good in patients, because not only do the fibroids shrink, they kind of soften. So I always use the analogy that instead of having like a rubber ball or rock in there, we turn it kind of into, it's not quite a water balloon, but it's much softer, much more pliable. And so that in and of itself can decrease some of those bulk-related symptoms. But again, it usually comes down to really having that expectations. So I also tell, patients, I'm not cutting anything out. I'm not removing anything. So you're always going to have kind of a scar of the fibroid. And depending, kind of older data looked at saying fibroids shrink about 50% over time. The more recent research shows that some fibroids can shrink up to 70%. Again, depending on where they're located. There's a submucosal fibroid. I do, meaning it's on the lining of the uterus. There is a potential that after we take away the blood supply and it starts to shrink, that fibroid can detach and you may end up passing it. There's something called bulk fibroid slough. And so then the fibroid shrinks even more. But sometimes we actually do have to have the gynecologist, if it's a big fibroid and you start to pass a lot of that, we actually have the gynecologist go in with their hysteroscope and actually remove that fibroid, and people get really good responses. So again, it's a wonderful technique. It's been around, but again, making sure you have the appropriate workup for patients before we do the fibroid embolization. And then I always say follow-up is very important. We do an MRI ahead of time to kind of understand size, number, location, blood flow. And then we want to do that follow-up MRI depending on where you go, anywhere from 3 to 6 months. Some people do a year, just to make sure you responded appropriately to treatment.
Thank you. And I do want to share that, when with my sister, the first treatment that they gave her was a Eufy to really control the bleeding to start, so that the blood thinners would not kind of just be fighting with her vaginal bleeding. So it's also used as part of a larger treatment with a very complicated case. So that was certainly very helpful because it did stop her bleeding. Okay, so let's see. We're coming up on 4 minutes left. What I would like to do is to go ahead, and I don't want people to feel like we didn't. I would like to take these questions, and we can see if we can, provide some answers. And I think we have all of the emails. Is that correct, Encom? Because I don't want any folks to feel like, but we will also, I hope we've whet your appetite for more information to come. I know Dr. Stewart knows, and Dr. Wolf and I often have conversations that go hours about research and about what's going on, and sometimes venting, just frustration with what is not going on and not moving forward with addressing, kind of fibroids and better treatment for women. And so, yes, there will be a replay available, so you can rewatch this. And so I do want to ask Dr. Stewart or Dr. Wolf, kind of what would be your parting comments as we close, just to say to the women that are out there and kind of jumped on this to get more information, and particularly about heavy bleeding.
So I think educate yourself that there's a lot of quality websites available. We've talked about the Mayo Clinic website, the ACOG has a site, the American Society for Reproductive Medicine has a site. So I think you want to vet the quality of the information you're getting, but if you educate yourself before you go in to see a provider, then you can ask the right questions. And if you're not getting any response, then looking for another provider can be a good answer too.
Yeah, and I'll just kind of say the common thing we say all the time is, just with the education, just kind of taking into really understanding or questioning what a heavy menstrual period is. Because again, a lot of times it's been normalized either through your friends, your sister, your family, your mother. So I've always had heavy bleeding, so you just don't know what the difference is. Or even sometimes going into providers can sometimes even normalize those symptoms. So really trying to just start the conversation, taking notes, records, charting in your, on your phone, on a calendar, just anything to kind of chart and track down how heavy your periods are, how much they last, how many tampons, pads you go through, can really help creating that conversation and having some good information to discuss with your care provider.
And I want to thank Dr. Stewart for joining us. We were so excited that she was actually available. Our schedule is quite
sure.
And I want to just echo kind of what Rochelle was saying about, kind of this normalization, which is really what we were after. We hope that you've been educated and continue to, as Dr. Stewart said, educate yourself, but educate others. you know, really kind of check in with others. I always say that I'm the queen of TMI. Like, you know, my brother hears about my period and he has no interest in my period. He has said so. He said, please don't talk about this at the dinner table. But I think that we need to normalize conversations around this. I think part of, you know, kind of our culture is that whatever happens down there stays down there. It's kind of a Las Vegas approach. And I think that has led to kind of not really knowing what heavy bleeding is and kind of having these terms that don't have a lot of detail and meat to them. So I definitely encourage you to not only get educated, but also help to educate other sisters, aunts, friends, and leverage one another, especially given what we talked about in terms of mental health, because we need support. And that's what the White Dress Project is here for. And I'm going to make my last request for you to do the survey. And I'm going to send the link again for those of you who have not done it. For those of you who have done it, thank you so much. Thank you so much. The replay will be emailed to everyone who registered for the webinar. We'll also include the links on the websites that Dr. Stewart referred to, and then any others that we would recommend. And then, yes, it'll be on YouTube as well, so that will be available. And we thank you. Thank you for taking your time tonight. Thank you for getting educated. Thank you for sharing your stories. And we look forward to seeing you next month. Happy New Year, happy holidays, and thank you.
Lovely evening. Thank you.